Good afternoon, everyone, and welcome to another edition of Inside University of Miami Medicine, U Miami Medicine to be precise. This afternoon, I'm joined by two outstanding individuals, so truly the thought leaders in medical education. We have the president of the AAMC, president and CEO of the AAMC, that's Dr. David Skorton, and also Dr. Alison Whelan, who is the chief academic officer of the Association of American Medical Colleges. I've had the pleasure of working with them fairly closely over the last several years, and it is truly a privilege to be able to welcome them to the University of Miami and Medical School of Medicine to talk a little bit about the challenges facing medical education in general. So, David, Alison, welcome.
Thanks. It's great to be here.
Yeah. You each have a unique path to those very prominent roles that you hold in medical education. So please just give us a brief synopsis of how you got to be where you are. Alison, why don't you start us off?
So I was a Midwesterner forever. That's relevant down here in Miami. Beautiful weather. When I entered medical school, I had actually no idea what I wanted to do. I went to a research-intensive med school and had an open mind. Actually loved the basic sciences, and so I thought I was going to be a basic scientist clinician. I did my clerkships, fell in love with internal medicine, so I became an internist and thought I was going to do basic science. I did 2 years of basic science research, and then I was chief resident in medicine. And that was a transformative year for me because we did a lot of teaching of medical students. Mm-hmm. I never thought I wanted to be a teacher, and I loved it. I loved teaching the students. I actually loved thinking about teaching. I loved thinking about the structure of teaching. And although I'm kind of a retiring person, I spoke up a few too many times and said, we could do this, we could do that, we could do this for students, and ended up really becoming an educator and became a clerkship director the year after I finished my fellowship. I was also a clinical geneticist, which is another part of the story in that I saw pediatric patients for the first time after I had finished my internal medicine training. Mm-hmm. So it gave me a great deal of humility in that I knew less about seeing a pediatrics patient than the third-year medical students did, even though I was essentially an attending in internal medicine. So I became an educator because I really followed my heart and followed my gut and was open to the possibility. So then I stayed at that school. I was clerkship director, course director, curriculum dean, and then became the senior associate dean over the continuum of education. And then had the privilege to join AAMC 6 years ago and really lead first medical education and then the academic mission at AAMC.
Okay, and a quick follow-up question. So why leave your position as a senior associate dean to come over to the AAMC?
So 2 reasons. One, on a personal level, even though there was great work to keep doing where I was. Sure. I like to be on a steep learning curve, and it hadn't totally flattened, but it wasn't as steep as it had been, and certainly at AAMC there was lots to learn. Okay. And I also thought it was an opportunity to both lead and serve, which is part of the mission. And the idea of doing for 150, now 157 medical schools, what I've been doing for one was just an incredible, great challenge.
Priceless. Well, thank you so very much. Wonderful introduction. David, tell us about your journey. I know it's just a short one.
So I was born in Milwaukee, and at age 9, we moved to Los Angeles. Okay. And I fell in love with the music scene in LA, and I was committed to becoming a session musician. I wanted to work 9 to 5, say at Capitol Records. Cool. And one little minor thing got in the way. Everybody in the entire city of LA was a better musician than I was. And so that didn't work out. I did go to college, first one to finish in my family, and my immediate family. And I went to medical school. Mm-hmm. And I was very interested in primary care. I directed the Division of General Internal Medicine at the University of Iowa for some years. Worked in the Veterans Administration with what we used to call continuity of care clinics. But I had also had cardiology training. Like Dr. Whelan, I was a chief medical resident, and my medical practice eventually focused on the care of adolescents and adults with congenital heart disease, So also something that touched on genetics, although without the expertise that Dr. Whelan had and has. While I was at Iowa, I did research in biomedical engineering and computer processing of medical imagery, and I had an appointment in engineering and in medicine, and eventually I did some university-wide administration and research, and then eventually became president of the University of Iowa.
Just like that?
Well, it actually was sort of just like that. And I was there for 26 years altogether, and then I was at Cornell University as president for 9 years.
Okay.
And then my love of the arts kept with me, and I had the opportunity to work at the Smithsonian. So I was secretary of the Smithsonian for 4 years. And then I had a chance to come back to the world of healthcare at the AAMC, which is really a fabulous organization, and jumped at the chance to do it.
Well, thank you. Actually, very fascinating journeys for both of you, and it's a reminder of your love for the arts in particular, that medicine welcomes just about all walks of life, and an appreciation for the humanities is crucial. So let's talk a little bit about why you're here in particular, which is you both presented at the International Conference on the Future of Healthcare, of Health Professional Education. Now, the AAMC has been playing a pivotal role when it comes to health professional education in general. We know that we just at the tail end, well, we are at the tail end of this global pandemic that really just turned everything upside down. Tell us about how the AAMC managed to handle the challenge of being the thought leader and really the advisor to all of the major organizations, the government, in terms of which path we needed to take forward to manage to provide optimal care during the pandemic, and also try to make sure that the course of medical education was not derailed during the whole thing. And at the same time, you're doing all of those things, if I understand correctly, with a skeleton staff, because you were not conducting business as usual. So that must have been quite a challenge for the two leaders of this great organization. So give us a little bit of a, inside baseball.
Want me to start?
Sure.
So I will start with the medical education, but I think this is true of all the aspects of academic medicine, which is the real leadership happened at our schools and at our hospitals. And
what do you mean by that?
Well, I was sitting at home and my colleagues, people who had the job that I used to have, I mean, I was a clinician as well, were continuing the education program as they were seeing patients.
Wow.
And as they were thinking about, how do I keep my students safe, how do I keep my staff safe, and how do I care for patients, and how do I keep my family safe? And the way that we led was actually truly by connecting with the people who were on the ground, whether it was in the clinical space or in the education space, and doing a lot of listening and a lot of bringing people together. You'll recall we started bringing the deans together on a weekly basis.
Right.
We did the same thing with the educators, so they could learn from each other, and we were learning, and we were listening deeply. We did have the advantage of having the opportunity to look at the entire nation and sort of get that environmental scan. But I think first and foremost, we need to really remember that the true leadership came from everyone who was on the front lines and everyone who was in the hospitals and at the medical schools. We had the privilege of listening to them and then had the brain space to step back and say, what does this mean? So yes, we came out with guidelines recommending that schools remove their students from clinical sites. Partially to protect the students, but mostly because we had a shortage of PPE. It was to protect the frontline workforce. So it was a privilege to be doing that, and then would feed it back and then listen again, gather information, and then again step back as well. But I think that's probably the most important message of what we did in that part. And David can talk about that we did have a connection with what was going on at the government side of things, which I think gave an important conduit for us to feed back to the schools and hospitals.
Yeah, and before I turn to David, I must acknowledge the visionary leadership or the clairvoyance of our chief academic officer in really bringing together all the deans in that weekly gathering, because we needed information and we needed to learn from one another. And it was the ability of your staff and you to bring everyone together and synthesize all the information, distill it back out, and let people know where resources existed. That played a pivotal role in making sure that our schools remain functional and our students safe. So thank you. I say that partly as the chair of the Council of Deans. So thank you. I never had a chance to do that. So thank you. I had to come here for me to be able to acknowledge it. So David, tell us, because you have an even bigger role. I mean, you're overseeing the entire engine, and you have to keep academic health systems and medical schools functioning, and keep the president happy, CDC, and so tell us a little bit about how you did it.
So this is going to sound like one of those things you say for the occasion, but Dr. Whelan and her team showed us the way forward. They had ideas, but they checked them out with the individual deans like yourself and learned a lot and got more ideas by listening. And that was actually the paradigm that we used for everything else. So let's say a policy issue like wanting to relax some of the regulations around the use of telehealth. Mm-hmm. We got the ideas of what to ask the government to relax by listening to our members, by listening to the faculty like the excellent faculty at the Miller School or other places. And everything you can go right down the line during COVID, we followed the very same paradigm. And the areas in which we followed that were policies, as well as regulations, as well as advocacy for specific kinds of legislation. For example, the length of time that the public health emergency would make it easier to relax some of these regulations. And telehealth is really only one of those. The other thing that we did, which was the brainchild of someone in our communications department, was to develop press conferences early in the pandemic. Mm-hmm. And I clearly remember, I wouldn't speak about any other clinician, but I was on talk about a steep learning curve. This was something I knew nothing about. And all of a sudden, a complex multi-system disease that was lethal. And this is before the vaccine, before Paxlovid, before really anything but supportive care. We had to find out by asking people in the front lines what they were doing. And as you recall, some of our members were really up against it on the front lines, being crushed by not only the medical work, but the emotional work of watching people die, patient after patient after patient. Right. We're not really trained in general to watch people die as one of the main things that we do. And that was very hard on the clinicians and the nurses and everybody on the team, as it was, of course, on the families themselves. And so we did the same thing, followed the same example, the same great example of Dr. Whelan and her team listening to the members, and then a feedback mechanism. And the press conferences allowed us to bring forward the members' ideas in answer to questions from the press. And it was fascinating that the press showed up at conference after conference after conference, because everyone was hungry for information.
Exactly.
And one little piece of information on the science side, and Dr. Whelan talked about her background in basic science, we were all very excited about this amazing trajectory of 11 months from beginning to end of the first part of the Operation Warp Speed. But we're reminded of 15 to 18 years of fundamental research, NIH funded at medical schools.
That's right.
That led to the concept of mRNA being used as a platform, as a vehicle to deliver a vaccine that made it possible to do Operation Warp Speed. And so there was another example where the members would verbally, so to speak, grab me by the lapels and say, don't forget to make this a moment to remind the government that no matter what else is going on, we have to continue to fund biomedical research initiated by investigators that would someday lead to a life-saving maneuver like mRNA vaccines that would save millions and millions of lives. All of those things, as Dr. Whelan said, came by listening to our members.
Right. and reopen the economy, which so many people talked about. So that's remarkable, wonderful. So, in summary, what would you say we have learned from the global pandemic that will prepare us for the next pandemic? Isn't it? So it's a two-part question. The students, we've had several classes that have graduated by now. Have we gotten any feedback, whether through a graduate questionnaire or other people reaching out to the AAMC, letting us know how could we handle things better, if possible? And likewise, what preparations do we have that will allow us to confront the next pandemic, which will happen inevitably, at some point, in a more efficient, even better way than we did before?
So we could talk all day about the changes in education. I'll just hit a couple of high points. And that is very early on, as students were pulled from their clinical rotations, and this is in all the health professions, the schools became very nimble and creative in developing new resources and in sharing those resources. And I think to continue that is a great opportunity. Another opportunity was because we were inventing everything and creating things and needed new communication, those schools that involved students in every single aspect of what they were doing, how and when should we communicate? Will this new course work? Do you want to help create this new course? That happened at your school. Were the ones that were the most successful, and so we need to continue to keep students truly a part of everything that's a part of what they do. And then I think the last point that I would make is that even though we did take students off of clinical rotations for the reasons I had said before, that it is absolutely crucial that everyone know that students are critical. They are a part of the workforce, and that we need to continue overall their progression towards timely graduation so we can fill and have interns and continue to have the workforce. And that was a challenge, actually. Some hospitals like, we don't need students, but we had to get them back in. So I think those are three of the biggest learning lessons and opportunities for going forward.
No, that's a great point, because they are part of the care delivery team, so we can't just put them on the side and expect them to learn, I'm sure. So, David?
I think opening up the focus a little broader, we were not prepared for a pandemic. There's no way to sugarcoat that. We were not prepared for the pandemic. We saw the stockpile wasn't ready for use. Even though there were things there, the maintenance wasn't what it should have been. Our public health infrastructure, we're here in a medical school, the public health infrastructure has been an area that we have invested poorly for a very long time. And I think maybe there's a certain aspect of human nature that you want to focus on the thing that's right in your face right now. And the idea of investing time or money or effort into something that it's going to happen, but we don't know when, we don't know how severe, is something that we're just not very good at. I don't think I've been good at it in my career. I think many of us have that deficit in our thinking. And so I'm very worried that we're not going to be ready for the next pandemic because we still don't invest sufficiently in the public health infrastructure. And I'm not just talking about the Center for Disease Control and Prevention, which itself is underinvested, but the state and municipal and community clinics run by public health departments, depending on the state, and of course the states suffered enormous economic lapses during COVID. This area, because of the change in the hospitality sector, was particularly hard hit. Did not feel that they want to actually put more money into those things. I want to cite Dr. Rochelle Walensky, the current director of the CDC, who had the courage to say in public, the CDC needs to take a look at itself and make some changes. And she and her team are courageously trying to think forward. We should take that as an example, in my view, to be courageous enough to say, what can we do? And we already had another small outbreak that did become a public health emergency with monkeypox. And then our colleagues in Uganda, at least one of which was here at this wonderful conference, are suffering an Ebola outbreak. And very complicated situation, since there's no direct flights from Entebbe to the US. we changed the ways that people can get into the U.S. from Africa to make sure that we're keeping an eye on that. But our approach is very episodic. It's something that's in our face right now. Once this hopefully dies down and the Ebola outbreak calms down, which would be wonderful if that really happened, then we're going to be in the same situation of, are we going to actually prepare for the next pandemic? And so we learned that lesson the hard way, and I believe we're going to continue to learn it the hard way as a country if we don't begin to think about things that are not in our face right now.
Great. And talking about things that are not in our face, shift gears a little bit to talk about the strategic plan for the AAMC. When you came on, you embarked on this journey to create a bold vision for the AAMC, the strategic plan. Tell us a little bit about the thought process and then how you arrived at those 10 goals, and also what progress are we making towards them. And last but not least, is pandemic preparedness one of the added modifications to the plan?
These are very tough questions. I thought when you have a guest on a podcast, you're supposed to throw easy pop flies, not line drives. This is very disappointing.
That's a line drive for you.
Whatever. I'm not saying all these things to be friendly to Dr. Whelan, but when I first came in, I asked the leaders who were already at the AAMC and had much better grasp of the organization than I did, what was needed. And Dr. Whelan and others told me that some focus was needed because the number of things that kept piling up and piling up and piling up, and this was before COVID, was really unsustainable. And so we began a process of looking at what the future might bring. We had hundreds and hundreds and hundreds of inputs from member institutions. The last annual meeting, Learn, Serve, Lead, which was in 2019, we had an area where people could put Post-its in an area and give us more input. Dr. Whelan was one of the people on the writing team for the plan. She gets a lot of the credit for that. And we decided to do it, link arms with our board of directors so that we could do it together, not develop a plan and then begin to discuss it with the governing board and not vice versa, that the governing board have a plan. So we did it together. We erased that line between governance and management. And we had initially about 600 ideas that were given, 600 separable ideas. And Dr. Whelan helped us develop some themes, some general themes. We used those themes to narrow it down to about 100, which was still way too many.
Wow.
And then we used some creative and difficult discussions to lower it down to these 10. In the 10 themes, there were the creation of 2 entities, a Center for Health Justice, which has been going just about a year. Their 1-year anniversary was in September, or birthday, I should say, was in September. And then, first time in the history of the AAMC, a nonpartisan think tank, the AAMC Research and Action Institute, which is about that same age and putting out some papers. The other 8 plans deal with a variety of issues.
So let me interrupt for a second. So why did you think that think tank was so essential as one of the 10 to preserve out of 100?
We have some problems that we need to try to solve, and we need to be able to think, as the expression goes, outside the box. And so sometimes you have to have a mechanism in which to tackle something that you've never tackled before. And we thought that the possibility of a place to bring together the expertise at the AAMC, Dr. Whelan's a great example, but only one example of that, along with, say, an external advisory board, along with perhaps someone who could come as a fellow in residence, or actually a virtual fellow, would be a way to bring together expertise from the members, from the staff and what we call subject matter experts within the AAMC, and people that we really haven't been listening enough to. And so we decided to try an experiment. And of the other 8 areas, I would say the most prominent that cuts across virtually all of them is to focus on diversity, equity, inclusion, anti-racism, and justice. And we have plans that are trying to deal with the shameful lack of black men in medicine. The year of my first faculty appointment at Iowa, which was the 79-80 academic year, 3.1% of matriculants were black men. That's the same percentage to the decimal point as 2 years ago. And so that's a shameful record of my generation. And so we decided to emphasize that and also emphasize the culture, the climate of our great institutions of higher learning and medical education. And then there's many other things.
Sure. Great. I'm going to come back to the DEI issue, but first let me ask Dr. Whelan to talk a little bit about, I believe it's strategic plan number 3, strengthening medical education. So tell us a little bit about what that entails and how we're going about implementing this objective.
So we're bolder than that. It's transforming medical education.
Good.
And as we thought about it, it has a lot of different components. But the central part of it is really accelerating and solidifying the commitment to competency-based education.
Okay.
And as we
And why is that important?
So why is that?
Yeah,
So when we think
what's
about
wrong with the old way of doing things, huh?
So, and it's become sort of a buzzword, competency-based education. But I think the key things about that is that what drives the competency-based education is truly patient-centered and thinking about what does society and community need and what do our patients need. And that should drive how we decide what our practitioners, so medical students and residents, and importantly, through the continuum, what do practicing physicians need to continue to learn and be able to do? So that's the fundamental start of it. The second part of it is, as we think about, how do we know if we're getting there, is it's looking at the outcomes. So having different kinds of assessments. Yes, knowledge is important, but competencies are much more than that. So it is the communication and how you connect with your patients and how you think about all those aspects of what it takes to be a physician. So I think that's an important part of it as well. And then the third part of it is that, how we expect our learners to go through the journey is different. In that instead of it the faculty person saying, learn this, do this, learn this, it's much more student-centered. So yes, they have to meet those competencies, but recognizing that students come in with experience and with knowledge. So ultimately, the best competency-based education is the student is engaged and thinking about what do I know, what do I need to learn, what skills do I need, working with their faculty, advisors, coaches, attendings, and moving at a pace that makes sense for them as well.
Got it. So it's about knowledge acquisition. Okay, you can ace the exam, but then you have to be able to apply it.
You need to be able to apply it, and you need to be able to think critically.
Okay.
And really importantly, you need to develop the skills of lifelong learning and the skills of a growth mindset. So being curious and recognizing that we're not perfect and we need to always continue to grow. So I think those are the other components that are critical to competency-based education.
Great. And how's that being embraced by all the other institutions, all the other medical schools?
So as you know, actually your school is a great representation of that. Many schools have begun that journey already. And as usual, as we said before, part of what we do is learn from what schools are doing and help schools connect to one another and see what are promising practices. But we're also trying to provide guideposts. So we have developed already, recognizing as medicine changes, education needs to change. And not just for the graduating student, but for the practicing physician. So we developed this set of competency sets for new and emerging areas in medicine. And the first one was quality improvement, patient safety. The second was telehealth, we started it before the pandemic, became very timely as it came out during the pandemic.
Prescient.
And then the most recent was the diversity, equity, inclusion. And the idea is not just what does a medical student need to know, value, be able to do the competencies, but what do residents need to do? And importantly, even if I'm out in practice, what do I need to know about telehealth to be able to both practice it and to teach it? So that's one set of things. And then the other is focusing at the medical student level to really help our schools connect across horizontally and then to connect medical schools with residency. Is we've just embarked on a project to develop a set of foundational competencies for every medical student graduating from any medical school. It won't be the be-all end-all. We would then expect your school to augment that with the things that are unique to your mission. Another school would augment it with the things unique to their mission. But the idea, if there was a core foundational set of competencies, that would help us translate the language from the medical student level to the graduate level, because as you know, there is a disconnect in that continuum.
You've been listening to part 1 of our Inside Your Miami Medicine episode with Dr. Skorton and Dr. Whelan from the AAMC. Tune in to part 2 to hear the rest of this fascinating conversation.